Hello, everyone, and welcome to the second webinar of the Society for Implementation Science in Nutrition. Today, we will consider a very basic question: why invest in implementation research, IR for short? I'm Gretel Pelto, and I serve on the SISN board. I'll be moderating our program today, which features 3 panelists who will address the topic of the seminar by sharing examples of implementation research in nutrition activities they have been involved in. Just a little housekeeping before we get started. If you have any questions during the presentation, and we certainly hope you will, please type them into the question box in your GoToWebinar control panel. You may send in your questions at any time during the presentation. After the 3 panelists have finished, we will have a question and answer session. We will try to include as many of your questions as possible. If you experience any technical difficulties, please also type your questions into the same question box, and our staff will help you address them. SISN is also active on Twitter, and we encourage you to chat and engage with us through our Twitter hashtag, which will appear today in the SISN chat box. A PDF of the slides and a recording of the webinar will be added to the member section of the website later. Now let's turn to the first presentation. It's a pleasure to introduce Dr. Eva Montarosa, whose presentation is entitled Using Stakeholder Analysis to Examine Acceptability and Appropriateness of a Nutrition Policy, an Example from Mexico. A word about Eva. Eva Montarosa is Senior Scientific Manager at SISN Life. She is a nutritional scientist who brings a decade of research and professional experience in maternal and child nutrition to bear on the issues she is discussing today. She works in the areas of formative research, project design and planning, monitoring and evaluation, and demand creation for culturally appropriate nutrition solutions. In her current role at SISN Life, she leads the implementation science area, managing a broad portfolio that includes food supplements and market delivery models, behavior change communication models for complementary feeding, women's nutrition, and nutrition and WASH. Eva also offers strategic advice to partners in academia and UN agencies on design and implementation of nutrition programs, and she assists WFP in behavior change communication. With this, I will hand it over to Eva for her presentation.
Thank you, Gretel. Good afternoon, everyone. Good morning. I'm very pleased to have been invited by SISN to discuss with you a very useful topic for IR. My talk will be about how stakeholder analysis can be used to examine the acceptability and appropriateness of a nutrition policy, and I will draw from a case that I worked on a few years back when I was in Mexico. So let's begin with a very basic question. What is stakeholder analysis? So stakeholders are any actors, that is people or organizations that have a vested interest. And a stakeholder analysis is a systematic approach to identifying the actors' interests, their position, and their perceptions of a nutrition action. And there are various ways that one can understand a stakeholder perspective. When this analysis is conducted before a nutrition action is implemented, policymakers and program managers can detect and act to prevent potential misunderstandings and/or opposition. For example, data from a stakeholder analysis can be used to design an advocacy and communication plan or for negotiating key issues. Of relevance to implementation research, stakeholder analysis can be used to inform the acceptability and appropriateness of a nutrition action. I want to briefly talk about the common stakeholder methodologies you will encounter in this space. The influence and power grids are popular tools because they're very easy to use, and these involve plotting your stakeholders on 2 axes. One axis for power and the other for influence. These grids are then used to identify which stakeholders must be actively engaged and those who only need to be kept informed. Q methodology is more complex and requires training and special software, With Q, you rely on predetermined statements, which are given to a broad number of people, who then must rank these statements based on how well the statements reflect their viewpoints. The grid and Q methodology are very useful when you have anywhere between 40 to 60 key stakeholders. If you need to solicit input from more people, then you can implement a qualitative survey, where you can understand people's interests, their position, the values, among other things. And this type of survey requires some level of expertise in interviews and qualitative data analysis. If you have existing text or audio data, you can perform a secondary analysis. And this is the approach that I used a few years back, and I will discuss shortly in a case study. So where does stakeholder analysis fit within implementation research? It fits really well in the initiation and scoping phase because it is examining the stakeholders' perspectives, their positions, their perceptions, as well as the relevance and fit of a policy option with a putative problem. Stakeholder analysis can inform two implementation outcomes: acceptability and appropriateness. The level of acceptability might be influenced by the level of comfort or familiarity with the nutrition action that you are trying to implement. Acceptability is also influenced over the relative advantage of this action over other options, the credibility of the nutrition action itself, or the credibility of owners of this action. Appropriateness is the perceived fit or the relevance of the nutrition action for a particular setting, a specific target audience, or an issue. And notice that both of these outcomes have to do with stakeholder perceptions. So before I talk about the Mexico case, I must state that I was involved only in the analysis of stakeholder perspectives. I was not part of developing the guidelines, which I'll talk about shortly, nor did I participate in the policy process. This was done by the senior author of the paper, Dr. Juan Rivera, from the National Institute of Public Health in Mexico. So in 2010, Mexican health experts, along with officials from the Ministry of Health and the Ministry of Education, had developed and approved normative guidelines to establish clear rules on the type of foods that could be prepared, sold, or distributed inside schools, as well as the type of strategies to be used to promote a healthy eating culture in schools. The policy process in Mexico includes a public consultation period. The guidelines were published on a website and in a newspaper, and citizens were encouraged to submit their written responses via mail, email, or fax to the institution responsible for this process. After the consultation period ended, the guidelines were subsequently modified, and then they continued in the policy approval process until they became law. The responses from the consultation process were public documents, and in 2011, we conducted an in-depth analysis to answer a simple research question. What were the stakeholder perspectives on these guidelines? And perspectives is a fancy way of saying how stakeholders understand the problem and its possible solutions. I will not highlight the scientific elements of the stakeholder analysis, which you can read in the full text article that is now free access. Instead, in the next few slides, I want to revisit these data using an implementation research lens, and specifically to examine acceptability and appropriateness. So perspectives can be understood by identifying the issues. And the issue for us was those that made the guideline necessary or unnecessary. Perspectives also includes one's expectations, or what stakeholders perceive that would be gained, lost, or would stay the same as a result of the guidelines. It also includes any demands that are expressed by the stakeholders. So we applied Clark's definition of issues, expectations, and demand, and this definition became our analytical framework. And we coded 597 responses. And through the codes, we identified 12 different issues, 20 different expectations, and 17 different demands. And for this webinar, I will quickly present the codes that identify the top 3 responses for the issues, expectations, and demands. So on this table, in the top row, we have 5 actor types. And in the left column are the top 3 codes for the issues, expectations, and demands. The table shows the number of times the codes appear in the responses expressed as a percent. Let's look first at the food industry perspective. For them, the guidelines would not solve Mexico's obesity problem. It would result in a loss of jobs due to a loss of income from the companies, and they demanded a fair treatment to their products. Compare this perspective to the perspective of the 4 other actors. The issue for these actors was that Mexico has an obesity problem. They expected the guidelines to improve children's eating habits, and they demanded that junk foods be removed from schools. So what do these findings mean for implementing the guidelines? Well, essentially we have 2 divergent perspectives. The guideline was acceptable and appropriate to parents, health professionals, the citizens, and academics, but it was not appropriate and it was not acceptable to industry. Now, this is not an unexpected finding. And in fact, some would argue this is quite an obvious finding, and it is. But the nuance is in how the issue is framed by stakeholders. In the Mexico case, the issue driving the guidelines was to create healthy eating habits in the children, which included getting junk foods out of schools. The predominant issue perceived by all actors was obesity. And this shifted the argument to calories, portion sizes, and good and bad foods. And in fact, the major changes to the guidelines were on calories and package size, and most of the changes were in favor of the food industry. The appropriateness of any nutrition action might be improved if all stakeholders recognize the same problem, and at the same time, all stakeholders recognize that the nutrition action is the appropriate solution. That is, one needs to have a clear and consistent message between the problem and the proposed solution. In this case, the data from Mexico show that one would want to align the guidelines on the issue of eating habits of children at school, rather than obesity or other chronic diseases. And some examples of activities that could be informed by a stakeholder analysis to further drive alignment would be to create an engagement plan for key stakeholders, perhaps designing a large media campaign to draw public interest and support, or enlisting consumer and advocate groups to help amplify your message. Not only can you use stakeholder analysis to align around the issue, but you can also use it to identify potential shared interests among the different stakeholders, interests that could be further leveraged to promote the aims of the guideline. The other interests revealed in our data were a desire for healthy food options or a healthy food environment, even if it meant allowing processed foods in schools. There was a desire for nutrition education and using this to promote better eating habits among the children. And there was also a desire for a multi-actor approach. So in summary, a stakeholder analysis can be useful when perspectives are likely to be divergent. Ideally, you want to conduct a stakeholder analysis early in the planning process. If you decide to collect primary data, I would suggest doing a qualitative survey or a Q methodology. And unless you have qualitative research experience, this is something you would hire a professional to do. You can also use secondary data, such as existing memos or meeting transcripts if you have those, or, as we did in our case, web responses. A stakeholder analysis can still be useful even after an action has been implemented. You might learn who supports the current action and how you might foster further support, which is especially relevant when policies or programs are vulnerable to changes in government. These data and the findings that are generated from this research exercise can be used to present options for improving the relevance of and agreement for a nutrition action. So in conclusion, to improve appropriateness and acceptability, a stakeholder analysis may assist with finding points of convergence and shared interests, as well as supporters, both the likely and unlikely supporters. And it can assist with identifying the issue frame and helping you shape the discourse and support for your nutrition action. Thank you for your attention.
Thank you, Ava, for this very thoughtful presentation. I'm sure that those of you who are listening must have a number of questions now that you'd like to ask, and we hope that you will avail yourself of this strong system, or this strong method, if you will, of the webinar structure, which gives you a chance to introduce your questions at any time, including right after a speaker. Okay, now it's my pleasure to introduce our next speaker, Dr. Alison Tumilowicz. She is the Senior Technical Specialist in Monitoring, Learning, and Research at GAIN. Her presentation will cover MNP interventions in Ethiopia and Mozambique and the use of implementation research in program delivery. Alison has more than 15 years of experience in the prevention and treatment of undernutrition, management of country-level operations, development of global technical guidelines, and implementation research. As Senior Technical Specialist in Monitoring, Learning, and Research at GAIN, Alison is strengthening both research and utilization of evidence to improve program design and delivery. Alison, the floor is yours.
Thank you, Gretel, and thank you for the participants for joining the webinar and giving me the opportunity to share about recent work that GAIN completed in the area of micronutrient powders, or known as MNPs, in Mozambique and Ethiopia. So from 2012 to 2017, GAIN worked with the governments of Mozambique and Ethiopia to pilot for the first time the integration of micronutrient powder delivery into the existing infant and young child nutrition services. And in this presentation, I will describe the MNP delivery models, the design of formative evaluations that we conducted, and share with you some of what we learned. And I hope through this presentation to share examples which emphasize the importance of implementation research and the use of mixed methods when learning about how to design scalable, effective nutrition interventions. And in SISN's classification scheme of implementation research, this project sits at the intersection of nutrition-specific interventions and implementation, iterative improvement, and scaling up. So I'd like to start with just a bit of background on MNPs. In many low-resource populations, access to nutrient-dense complementary foods is limited. And MNP is recommended by the WHO to improve micronutrient content of infant and young child diets. And MNPs are single-dose packets of dry powder containing lipid-encapsulated iron and other micronutrients that can be sprinkled onto any semi-solid food. And studies have shown that adding MNP to complementary foods reduces the risk of iron deficiency anemia. And as of 2014, UNICEF reported that 50 countries are implementing MNP programs. In Mozambique, the Ministry of Health requested development partners, including GAIN, to test diverse delivery platforms across different regions of the country. We worked in Sofala province. We developed a design using vouchers aimed at making MNPs more accessible through multiple distribution points located in communities where caregivers live, and thereby alleviating the burden on the public health supply system by using a market-based platform. We worked with Population Services International, or PSI, to import the MNPs, and PSI also produced paper vouchers. PSI then provided the MNPs to small shops, which they had contracts with to redeem the vouchers. These shops were referred to as troca akis. PSI provided the paper vouchers to Save the Children, our other collaborator and partner. Save the Children, in turn, directly distributed the vouchers to caregivers through activistas, or community health volunteers, and health promoters that were stationed at the health centers. Save the Children also provided vouchers to the Ministry of Health centers, and Ministry of Health staff then provided vouchers to caregivers. There was also a mobile platform for electronic vouchers that was used much less frequently. It was mostly the paper vouchers that were distributed. When a caregiver received a voucher, she then went to the troca aki and exchanged her voucher for 3 boxes of MNP, which included 60 sachets, to be used over a period of 6 months. In Ethiopia, the delivery model was different. We worked with the Federal Ministry of Health, who asked GAIN to pilot the delivery of MNP through the Health Extension Worker Program in Tigray and Amhara regions. Health extension workers are paid employees of the Ministry of Health and provide basic treatment and preventative health services in predominantly rural areas. GAIN, in collaboration with Concern Worldwide, provided the health extension work with the M&P, supportive supervision, and training. In Ethiopia, we did not use vouchers. We directly distributed M&P through the health extension workers. The health extension workers then provided caregivers and their families with the M&P, as well as behavior change and communication materials. They conducted cooking demonstrations, and they also did individual counseling with caregivers on M&P and infant and young child feeding. So the goal of the governments of Mozambique and Ethiopia was to reduce iron deficiency anemia among children 6 to 23 months of age. GAIN's objective was to support the governments to test the viability of the distribution models to motivate improved IYCF practices and M&P use among the children. To do this, we conducted formative evaluations. And the formative evaluation design was similar across the two countries and consisted of 3 components. The first was multiple cross-sectional population-based surveys, the last one being after 12 months of implementation. And the aim of the surveys were to identify bottlenecks in the program delivery and adherence to M&P recommendations. So we looked at asked caregivers if they'd ever heard of M&P, ever received M&P, ever used M&P, if they were continuing to use M&P in the time period before the survey. We did not look at biological impact. We were really looking at coverage and adherence. In Mozambique, we also asked about if the caregivers received vouchers and if they redeemed those vouchers. In the second component of the formative evaluation, we conducted focused ethnographic interviews with caregivers. In Mozambique, we conducted 60 interviews in 2 districts of Sofala province. And in Ethiopia, we conducted 30 interviews with caregivers. The third component of the formative evaluation included surveys and in-depth interviews with program implementers. So now I'd like to talk a little bit about what we learned. In Mozambique, we found through the N-line survey that the voucher system was circumvented. To our surprise, about 75% of caregivers who received M&P did so directly without receiving a voucher. In interviews with caregivers and program implementers, we learned that frontline workers, the activistas, and the health promoters recognized the difficulty experienced by caregivers to redeem vouchers and therefore did it for them. They took the vouchers to the shop owners, redeemed the vouchers, received the M&P, and then distributed that M&P directly to caregivers. In Ethiopia, through the N-line survey, we learned that about 70% of caregivers heard about M&P and received M&P, and only slightly less, 60%, gave M&P to their child. So there really wasn't a bottleneck between hearing about M&P, receiving M&P, and trying to give M&P. However, only about 30% of caregivers reported using it in the 14 days preceding the survey. And through the N-line survey and caregiver interviews, we learned that there was confusion about how to obtain additional supply of M&P. What had happened is that health extension workers had given caregivers appointments, which they wrote on a child health card. However, if the caregiver lost the card or could not read the card or missed the appointment, she didn't know what to do and didn't know that she could just simply return to the health post or health extension worker to receive additional M&P supply. If the supply was not an issue, caregivers shared with us that they experienced difficulty, some caregivers experienced difficulty to feed M&P when their child refused food with it. And some caregivers found strategies to overcome child refusals, but others could not despite their best efforts. And the underlying reasons for their difficulty were in part due to the dynamic process of complementary feeding and child development and general challenges with complementary feeding, not necessarily related to M&P. So our recommendations for Mozambique included that if the public health supply system can provide a consistent supply of M&P, then it's not really useful to use vouchers. If the public health supply system cannot provide a consistent M&P supply, then the system needs to be redesigned and strengthened, the voucher system. In Ethiopia, the process to obtain new M&P supply needs to be simplified. And for both Mozambique and Ethiopia, to ensure sustained use of M&P, caregivers need to follow Caregivers need support to follow preparation instructions, strategies to overcome children refusing food, both with and without MNP, and knowledge of the side effects of what to do when children are sick. So to conclude, we needed surveys to identify bottlenecks, and we needed focused ethnographic interviews to understand why these bottlenecks existed. And Mozambique and Ethiopia are examples that demonstrate how different data collection methods complement each other and are needed to fully investigate program delivery processes. Lastly, I'd like to acknowledge the great number of people who worked in implementing the programs as well as on the evaluations. This was a huge team effort, and I'm presenting on behalf of all of us. Thank you very much.
Allison, thank you for this very rich presentation. Again, I expect that all of you who are listening will have lots of questions, and we will have time for them at the end of the panel session. But first, I'd like to introduce to you our last presenter, Giulia Baldi. Giulia's presentation is titled, "The Fill the Nutrient Gap Tool, Taking Analysis to Action to Improve Nutrition." Giulia is currently co-leading the Fill the Nutrient Gap, FNG for short, team in the nutrition division of the World Food Program in Rome. She has 15 years of experience in program and policy-related work on nutrition, health and food security in United Nations contexts. She has previously worked in WFP programs in Peru, Afghanistan, and Indonesia. She also has experience in child survival-related programs with UNICEF. Over to you, Giulia.
Thank you very much, Gretel. And good afternoon and good morning to everybody. It's a real pleasure to actually have the opportunity to present to you and to give a brief introduction of what Fill the Nutrient Gap tool and analysis is. First of all, trying to understand a bit the rationale for this analysis. It's just meeting the SDG 2, and in particular SDG 2.2 of ending all forms of malnutrition, urgently requires countries to come up with a mix, the right mix of interventions to actually effectively address malnutrition in different forms. And even though evidence exists, like for example, the frame, like what is explained in the by the Lancet series from 2013, actually finding the right combination adapted to the context is not always the easiest of the challenges for a country. And actually, Fill the Nutrient Gap tries to actually help and facilitate that identification and prioritization of a set of solutions. In particular, it's the focus of Fill the Nutrient Gap. If we look at the malnutrition framework, actually focus on the left-hand side of the malnutrition framework, so on the barriers that actually affect dietary intake, starting from the assumption that meeting nutrient requirements is a fundamental prerequisite for prevention of malnutrition, and actually understanding what type of barriers are affecting dietary intake, access to food and nutritious foods, and also practices and nutrition practices for different target groups and for vulnerable groups is essential to actually coming up with that set of solutions that are adequate to the context. And when we focus and we look at the focus on dietary intake, nutrients and the importance of nutrient intake is essential. And in particular, good nutrition is about consuming about 40 nutrients in different amounts for a wide variety varieties of foods, and of course, together with other key interventions. Therefore, the development of this tool and this analysis was started by WFP in collaboration with technical support from different partners, research partners that you can see here, and with support from bilateral donors, in particular Canada and Germany. And it started in 2015 with 3 pilots in El Salvador, Ghana, and Madagascar. But now it's already after a validation process that actually involved the support from the research institutes and the partners that I was showing before. It's now in the rollout phase, and it's already been applied in about 13 countries, and with a list also already coming up for 2018, and in different contexts, so in different continents. So as I was talking or mentioning before, so the main goal of Fill the Nutrient Gap is actually to strengthen nutrition situation analysis, but linked to decision making and the identification of prioritized solution, in particular with a focus of improving and addressing barriers to nutrient intake. And also, the other objective is to create a consensus among national stakeholders and different sectors that need to be involved in those sets of solutions to actually identify and prioritize strategies to improve nutrition of these target groups. The analysis actually uses two main components. One is a review of quite a comprehensive review of different types of secondary data and sources of information that are relevant to nutrient intake and nutrient access. And also the other part is actually linear programming using the cost of the diet. The focus, as I was mentioning before, I mean, it has a life cycle approach, but in particular also dives into particular vulnerable groups, and in general, particular emphasis is on children under 2, pregnant and lactating women, and adolescent girls. When I talk about secondary data and secondary sources of information, there are basically 6 main categories that are looked at that are relating to malnutrition characteristics of a country, and then the enabling environment that goes into policy programs, as well as strategic partnerships and public-private partnership initiatives that, for example, are related to improving availability or affordability of different types of nutritious foods in a particular country, and then information that relates to access and availability of nutritious foods, nutrient intake, but also qualitative information that looks actually at the consumer and demand side of for nutritious foods in a particular context, using qualitative information such as formative research that exists, focus ethnographic studies, but also consumer insights from the private sector, for example. And then we have secondary sources that are also used for the cost of the diet, including expenditure data and, when possible, actually market data. When we cost of the diet and the linear optimization, I'm going to quickly explain how it works, just to explain like the process, the process through which we go through. So linear optimization basically works based on what is the local, all the foods that are locally available in different markets in a particular context. And when we look at the different possible combination of these local foods to meet the nutrient requirements for a model household for a particular context that in general has a special particular composition, but it would be in general about, for example, five-person household with 1 young child under 2, a lactating woman, an adolescent girl, school-age child, and an adult man, for example. And all these possible diets that are meeting all nutrient requirements for this household, identifying which one would be the cheapest possible combination of these locally available foods. And then actually trying to adjust that also for staple preferences to actually look at what would be something that actually is more representative of a slightly more typical diet. And then comparing that to what people are currently at the food expenditure in that particular context, try to understand affordability issues and basically affordability of that cheapest combinations of food and this cheapest nutritious diet for that context, and trying to understand, so what or to what degree affordability of nutritious diet is a barrier in that context, and where and how. And then identify solutions that could be devised across different sectors and different systems, including social protection system, health system, and the food system, to improve the affordability of those nutritious diets. And this is actually a process that is done in country with multiple stakeholders and multiple sectors, including and under the leadership of the national government, and wherever possible, actually, for example, scaling up nutrition platforms or ready platforms that have a convening power of different sectors and stakeholders. And then WFP, other UN agencies, and other partners, including NGOs, academia, private sector, and development partners. And how is this analysis actually used and has been used, for example, in the pilot countries that I was mentioning, El Salvador, Ghana, and Madagascar? So the analysis is usually used to help and guide the dialogue around solutions that, for example, in El Salvador, help thinking how social protection programs, for example, could be made more nutrition sensitive as part of a national redesign of social protection programs. Or, for example, in Madagascar, to redesign the new nutrition multi-sectoral nutrition policy and action plan. And also, like for WFP, also it has helped and informed the strategic process and strategic planning process that the WFP country offices are going through, and vis-a-vis national government and other partners, actually in trying to bring forward the zero hunger agenda. So we don't have time to actually go into a full example of what type of insights we get from the analysis, but this is actually showing you an example from Cambodia, where you can see how we can try to triangulate information from secondary sources and the cost of the diet analysis, and trying to see, for example, prevalence of stunting in children under 5 by different regions, but then trying to correlate it with the cost of this nutritious diet, of this cheapest nutritious diet, and the non-affordability, and identify most vulnerable areas where actually the three, for example, coexist, or areas where, for example, we see that non-affordability and malnutrition don't really correlate that well, and trying to understand then what other factors might be there, like in terms of, for example, behaviors and practices, beliefs, or also, for example, something that has to do with disease and WASH. And also the cost of the diet, beyond like finding and identifying affordability issues, then helps model different types of interventions and of nutrition specific and sensitive interventions that could be devised using different entry points and the market to actually address and improve affordability of nutritious diets for household, and also reducing costs to meet nutrient needs for specific target groups. Example of strategies that are modeled through the cost of the diet are intervention for the general population, such as fortification of staple foods, or, for example, different types of homestead food production, and then intervention for specific target groups that could be, for example, including specialized nutritious foods through markets or social safety nets, or improved availability at market level of different types of unfortified nutritious foods, or biofortified crops, for example, and then other strategies that include increased income for the poorest. That could include cash transfers, but could also include increased income that, for example, is related to an increased investment in agriculture that then increase the incomes of, for example, smallholder farmers. So then this set of solutions are compared and discussed with the stakeholders, and that then together then identify needs for prioritized interventions in the short term, medium term, and long term, and then come up with a consensus on what is kind of like that set of interventions that they believe that actually is coming out of the findings from this analysis. And these are examples of key recommendations, for example, in the social protection area. Here includes, for example, changing, for example, the amount of the cash transfer and the transfer value of a conditional cash transfer that is provided by the social protection program, or, for example, in changing targeting, or including, for example, specialized nutritious foods, for example, a fortified infant cereal for a young child, to the population that is receiving, for example, the social protection program. And these are just a few examples. Other examples are, for example, in the food value chain, and there are actually usually recommendations are divided by sectors. And here, for example, an example from Ghana is actually improving supply chain, including cold storage of different types of fresh foods, in particular in areas that are particularly have market access issues and more geographic access issues. Then there are issues that are related to the regulatory framework and the harmonization of regulatory frameworks for fortified foods, for example, between provincial level and national level in very highly decentralized settings like Pakistan. And these are, and you can see other recommendations from here. If we look at how the Society for Implementation Science classification, this tool helps actually, in particular, in the initiation and scoping, and as well as planning of design in the intersection between nutrition-specific intervention, nutrition-sensitive actions, and also the operationalization of national multi-sectoral nutrition agenda. And if you are interested in actually seeing specific country examples that I was mentioning before, and also more on the concept and the approach, please, this is the link to WFP Nutrition page, where you can find a lot of information, as well as previous webinars that we have done. Thank you very much, and pleasure to be with you.
And thank you very much, Julia, Alison, and Ava, for these insightful contributions. It's now time to engage in some question and answering. We've got about 15 minutes before we have to close, maybe 12 minutes. And so I am a little surprised to see that my inbox is not being flooded with questions, but I suspect you have some. As I look over the list of the questions that I scribbled while I was listening to you, I see that my questions fall into two basic categories. One category has to do with the methods that you've used and methods development. Not a surprise for those of you who know that I am working in SISN in the methods sphere. And the other are questions that have to do with the dynamics of what goes on when you engage in this kind of work. Now, ultimately, the question that the issue that this webinar is intended to address is the matter of why we should engage in implementation, why we should put resources into implementation research. So let me just start out with a couple of questions that I jotted down as I was listening. I'm going to ask Alison the first question, and I'd like to find out from you how important you feel it was to use a mixed method approach in the studies that you've presented. And specifically, how important was it from the perspective of decision-making about next steps?
Thank you, Gretel, for the question. I think it was critical, and I don't think that we would have come with the recommendations that we did to the governments if we didn't have both the survey and the focused ethnographic interviews. As I mentioned in the presentation, the only way really to measure the frequency of the caregivers receiving the vouchers or receiving MNP in the population was to do a survey. So in order to identify where the bottlenecks were, we couldn't do that through interviews. The interviews may have pointed us to where there might be some problems, but we wouldn't have known the extent of those problems if we hadn't done a survey. And on the flip side of that, we would never have known the reasons why caregivers were having trouble to redeem vouchers, or having some caregivers were having trouble to continue using MNP had we not done the focused ethnographic interviews. So I think both are critical, and I think that any formative, my personal opinion is any formative evaluation or process evaluation has to use mixed methods, or else we'll only have partial answers to the questions about what's happening from going from inputs to outcomes and eventually biological outcomes.
Good. Thank you. I'm going to shift from a more methodological question to a more substantive or process question, and ask Eva, I hope this is not going to be sort of a from left field kind of question, but I am struck by the problem of, or the potential problem of, differences among the stakeholders that you highlighted so obviously in terms of what was important to them. And I wonder whether the project developed any mechanisms for providing feedback to the different stakeholders about the results, and any methods to, or any processes to resolve conflict among the stakeholders, considering that there was pretty significant differences.
Yes, Gretel, that's a hard question, in part because I was not involved in the policy process. So as I mentioned, I did just the stakeholder analysis. My understanding of what had happened in Mexico when I came in to do this analysis was that it was a very contentious issue, the passing of these guidelines, and it was, as you saw in the data, quite polarized. And there was a lot of lobbying being done from industry to sort of water down the guidelines. And the guidelines were quite prescriptive, so to speak, in terms of what could be allowed in schools. And so there was a great lobbying on behalf of the industry. We did. So some of the co-authors for this study were part of the policy process. Now, to what extent this actually unfolded in the background, either with engagement of key stakeholders or other discussions, that I don't know. But it's, once you have this information, it actually points to opportunities for different avenues to negotiate, to find areas of common interest, even if these are not widely shared. As you saw in one of my slides, some of these areas were healthy food choices, and percentage-wise, it was somewhere between 10 and 15%. So it wasn't as big as, let's say, obesity, that was falling under the 30 or 25% mark. But at least these are what one might call areas of shared interest. And this can be further developed and further taken on by policy entrepreneurs or people who are involved in the policy process. I hope that answers your question.
Thank you. I think that was a fascinating answer, and I didn't mean to throw you a curveball. I have a question also for Julia, which I think also fits into, it is sort of a larger issue. Julia, how did the UNICEF framework inform your decisions about what to include in the tool? And was there a process to select items in relation to that framework. You gave a very clear explanation of of what went into the decisions, but I wonder how some of it obviously relates to the framework. Other aspects are less clear. So I wonder if you could tell us more about that.
Yes. Can you hear me?
Yes, I think we hear you.
Okay. Okay. No, what I was the reason why I showed the framework, the UNICEF framework, is just to highlight the focus of the Fill the Nutrient Gap on dietary intake and barriers to adequate dietary intake, as more related to kind of the left-hand side of the malnutrition framework, not disregarding the importance of disease and access to water and sanitation as important aspects and contributor to malnutrition, but actually emphasizing the fact that the Fill the Nutrient Gap is a tool that helps zooming in on the factors that are contributing to inadequate dietary intake, in particular in relation to access to food, availability to food and nutritious foods, as well as some of the cultural factors and barriers that are affecting the adequate consumption of nutritious foods. So just to show if you want, the limitations of, but in particular also the focus of this analysis. I don't know if I've answered your question.
Well, yeah, I mean, I think it's a very thoughtful answer. Now we're starting to get some questions in, and we have only a very, very few minutes left. So that means I have to select from the various questions the one that's zeroed
So
here.
Gretel, may I make a comment, perhaps while you're looking at the question box? You know, Julie, as I was hearing your presentation, and you offer various solutions, you can say they're policy options to various stakeholders that are involved in Fill the Nutrient Gap. It would be very interesting, and I'd be happy to collaborate on WFP on this, to do a stakeholder analysis on how they perceive the different options and where there might be convergence or divergence on certain policy options. I think that might be another interesting endeavor. And then following on with those results to see how to further disseminate or draw support for particular policy options.
Yeah, actually, I was thinking of that when you were presenting your. It's actually very interesting because it's the process is actually bringing together very different perspectives, and it's actually interesting to see. There is a consensus building around or an alignment around solutions that are proposed. So basically, there's also a process that goes into that prioritization that also engages stakeholders directly in that prioritization, and so these different perspectives are taken into account. But it would be interesting to actually do a follow-up and maybe broadening even further and looking more at these different perspectives and how they're reflected in the different set of options.
Great. I'm not sure what happens at the witching hour of 12. According to my clock, it's only 4 minutes before 12. And if we get cut off, there are actually a number of questions I'd love to throw out to you, but I have a couple of, taking the prerogative of the chair, a couple of comments I would like to make, which is, since the basic purpose of this session was to ask why invest, that we would like to ask you, our listeners, we invite you to articulate for yourselves, based on your own experiences and values, as well as the examples and case studies, such as the ones we've just heard, answers to the questions that are posed in the title of the seminar. That is, what do you see as compelling arguments for why we should invest in implementation research? And if you wish to share these insights, we'd be very pleased if you'd send them to us at implementnutrition@gmail.com. On a related topic, we'd also like to ask you to send in ideas for future webinars to the same email. And don't forget, of course, to visit our website to stay up to date with society activities and learn about the various opportunities for engagement. After you leave today's webinar, you'll receive a brief survey about the webinar, and we would appreciate it if you would provide your feedback. I think one of them might be, could we have an hour and a half next time? You will also receive a follow-up email in a few weeks with a link to today's webinar recording and a URL of the PDF of the slides. So although I'm very, very sorry to cut this off when there are a number of interesting questions that have just surfaced, I encourage you to give us collectively those questions, share them with us, again on the website. Remember, SISN is your organization, my organization, all of ours, and it will only be as valuable as we each individually and collectively make it. So please, this is a plea for staying in touch, using the resources that have been set up for communication. And I strongly encourage those of you who have just submitted really interesting questions to the speakers to take advantage of the opportunity to ask them at implementnutrition@gmail.com. So I think that, unfortunately, we've come to unexpectedly to the rapid end of the hour, and I want to thank all of you for joining us and hope that you will join us for the next webinar and share with us your wisdom, your insights, and your issues. Thanks so much on behalf of all of us on the panel today.